Welcome to our final Triage Infection Control and Decontamination Focus Area session from Protocols to Impact, Strengthening Pediatric Disaster Response Across the Spectrum of Child Health Needs. Next slide. The PPN is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of several cooperative agreements. The content presented here today is that of the authors and does not necessarily represent the official views of, nor an endorsement by, the U.S. government. Next slide, please. There are no disclosures today. There will be information later on how those of you interested can claim your CE. Next slide, which I believe I will be turning it over to Dr. Nick Glum. Thank you.
All right, welcome everyone. The session objectives today are going to be to identify key considerations in pediatric response to hazardous exposures, including CBURN, decontamination, and infectious diseases, with special attention to the needs of children and youth with special healthcare needs and medical complexity. And then we'll describe the strategies to strengthen hospital readiness for pediatric decontamination and infectious disease events, including adaptations required to safely care for children and youth with special healthcare needs, and then highlighting practice changes and impacts resulting from the participation in the collaborative, including improvements in disaster preparedness and response for children with diverse medical needs. So we are super excited today to have Dr. Tyler Holschler, who is going to be presenting to our group today. As background, Dr. Holschler was born in Tucson, Arizona, where he attended the University of Arizona for undergraduate and the University of Arizona College of Medicine in Phoenix for medical school. Dr. Hochsler completed his emergency medicine residency at Sunrise GME in Las Vegas before returning to Tucson to complete his toxicology fellowship at Banner University Medical Center. Dr. Hochsler is currently working as both an emergency medicine and toxicology faculty at Banner in Tucson and routinely juggles a busy family life at home with his wife and two boys. So, Dr. Hochsler, thank you very much for being here today. Go ahead and take it away.
First, thank you so much for the introduction. And thank you all for having me. I'm honored for the opportunity to speak to you guys. I am going to be speaking today, first of all, from the media/supply closet here at the U of A. I'm in the College of Pharmacy today. At heart, I work in the community here in Tucson. I've had the opportunity to work with a whole bunch of really pleasant, hardworking folks at various hospitals, various EMS organizations, both at the university level, even down to critical access places here in Southern Arizona. And so I hope the perspective that I can bring is that of boots on the ground, of what is disaster management going to look like from the setting here in our general medical community. If you guys wouldn't mind advancing a slide. Some of my basic objectives I kind of want to get across. A lot of it I hope will be review for you guys. I understand we've already gone through a lot of these sessions, and I'm also a firm believer that repetition is the key to adult learning. And so some of these things are going to be review, and hopefully, if they get hammered on again, they will be cemented in your minds. We're going to talk about some pediatric specific needs, especially in the realm of decontamination and disaster management. And then one other thing that I want to bring in is that I don't want us to think that we who work at hospitals, we're kind of alone on this. I want to highlight other places of the medical community at large and other resources that we have access to in this kind of disaster medicine. I'm going to do it via a kind of a case presentation off of something that happened here in Tucson a couple of years ago. You can go ahead and advance the slide again. Perfect. There we go. So let's open with our case. You're working a busy shift in the emergency department or the ICU or wherever it is. Page comes out. My view is in the emergency department, but that's just because that's where I work. Page comes out from the radio room. We have multiple pediatric patients en route from an MVC between a school bus and a chemical truck. I always get a little bit nervous when I hear multiple patients coming from my radio room. I don't know about you guys, but definitely when I hear school bus, now I hear multiple pediatric patients, and all of a sudden, what's this chemical? Why is there a chemical truck involved? I don't need that today. This is probably a busy Monday. With that kind of presentation. I just want you guys to take a couple seconds and sort of make a list of things. What initial questions need to be addressed? And unfortunately, if you've spent a lot of time working in a hospital setting, you don't necessarily have all that much time to think about it. A lot of the ways that we have to handle these types of mass casualty events and disaster events is quick, decisive decision making. So take a couple seconds and think what initial questions do you think need to be addressed based on this call out from our radio room? And you can go ahead and advance my slides again if you could. Excellent. Here's the truck. I This one I borrowed from the actual disaster that we had happen in Tucson. And there's a lot of hazmat disasters which are not that visually impressive, but thank heavens this one is, right? Doesn't this picture say 1,000 words? Look at all of these poor cars that are lined up, just kind of wondering, what's that red cloud of noxious smoke heading in my general direction? I wonder if that's important. But yeah, here's our truck. Wonder what's spilling out of it. Um, you might also notice that the fire diamond for substance identification is basically worn off on the back of that truck, so that's good too. You can go ahead and advance the slides again. The questions that I kind of thought of is first, how many patients are going to be arriving? What volumes will I be dealing with in this situation? How are they going to be arriving? I had the good fortune of training in Las Vegas. My attendings who taught me were the same attendings that managed the Las Vegas shooting several years before, unfortunately. And one of the biggest things that they learned through that mass casualty is that the entry routes of your patients make a huge difference. The vast majority of our walking wounded are going to show up by the front door. They are not going to come through EMS channels like we would hope. What potential hazardous materials could be involved? All I've got right now is a cloud of red smoke, and I'm hoping for the best there. But as of right now, I do not have an ID on the substance in this chemical truck. Where is triage going to occur? Hopefully there's an amount that's happening before it gets to me, but can I guarantee that? Not necessarily. Um, this is you're hearing a presentation from somebody who loves toxicology, so we can assume that this is going to be a poisoning and a hazardous chemical exposure. But is that really going to solely be the case? Remember, this is still a motor vehicle collision. The majority of your morbidity from any MVC is always going to be traumatic. Is your facility set up to handle multiple traumatic injuries? Is your trauma team comfortable with the complication of a chemical exposure on top of multiple traumatic injuries? I love working with my surgical colleagues, and they're excellent at handling traumatic injuries, but every once in a while we have to kind of stick our minds together and handle these more complicated cases together. And lastly, whenever there's a chemical exposure, I think we can neglect ourselves and our staff in these situations. But let's not forget that decontamination is not just a matter of patient safety, it's also a huge matter of staff safety. What are we doing to protect ourselves and our coworkers in these types of situations? Good. I think the answers to all of these questions are kind of up in the air. I think we need to be ready to address them. And you may not have a super clear-cut answer to each of these. If you do, great. You work in a much more functional hospital system than I do. But if you're a member of the real world like me, these may still be questions that stick in our heads. Thank you. You can go ahead and advance the slide. I like to think and I like to hope that our EMS colleagues have really thorough field triage and decontamination stations set up. And I have seen this happen. And when it does happen, it is impressive and it is very functional. But in all reality, at a lot of our hospitals, our decontamination setup is going to look a little bit more like this next slide. You can go ahead and advance. Yeah, perfect. It's gonna look like this. If we're lucky, we have a shower. You know, I've certainly worked at a large hospital that legitimately had a shower and a curtain in front of the ambulance bay, and if decon needed to happen, I guess that's where we do it. My current community site where I do the majority of my shifts, we at least have a separate room for decontamination with multiple showers set up. And it's usually also being used as a storage closet, kind of like the media room that I'm in right now. If you haven't had the opportunity to tour your hospital's decontamination setup, I would strongly recommend it. It is an eye-opening experience. You can go ahead and advance again. What is our staff safety going to look like? Are we all going to have fancy level A protective gear like this? Probably not. Unlikely, which is honestly a curse and a blessing because I don't necessarily want to manage an emergency with multiple patients while I'm wrapped up in a bunny suit like this. I'm also not trained in level A gear. I know my EMS colleagues do have access to these, and I dearly hope that since they're the one that are going to be braving that cloud of red, obnoxious smoke. I hope that this is what they have on. I have had the opportunity to train with them, and I know this is what they do. But there's still things to think of. And I say curse and blessing because remember, we're now asking some folks to keep themselves safe, potentially in advanced protective gear, and also handle multiple pediatric patients while they look like stormtroopers in bright yellow bunny suits. You go ahead and advance. And in reality, at the hospital, what does my PPE look like? Level D, which is to say nothing, which is to say a plastic gown and a face mask and hopes for the best. Depending on where you work, some hospitals may have, hospitals should all have pappers, cappers set up in these types of situations and know where they are at your facility. But in the meantime, with the understanding that we may be working in the community, we may be working in some austere conditions. I hope if you're being exposed to an unknown chemical substance, you have more than this on, with the understanding that there's a good chance that this is what a lot of us are going to reach to, the kinds of things that we have at hand for personal protective equipment, which frankly, in an unknown chemical exposure, this isn't enough. Good. You can go ahead and advance again. Initial priorities. I think that in this situation, what I mentioned before is that early decisions need to be made and they need to be decisive. The most comforting thing your team can have when dealing with a disaster like this, the most comforting thing you can have is a firm leader. Depending on your situation, depending on what your facility looks like, that leader may very well be you. You guys chose to get educated on this, chose to get extra learning on this because you probably have some amount of leadership, and that leader that people may be looking to, like I said, might just be you. Being able to establish that early, have an idea of a command structure, who is from your facility standpoint, who's running the show, who is directing traffic, and who are you delegating to? Not only does that help things flow smoothly, not only does that help the right thing happen for the patient, it is very comforting for the rest of your staff that you are working with. It's one of the most helpful things for them. Open lines of communication. The radio room is fortunately already giving you updates, but that's going to need to be a two-way radio room. There's going to need to be a conversation to and from the hospital between the emergency department, your trauma department, um, the accepting potential admitting teams in the ICU on the medical floor. And also if you're a community shop and you're picking up a lot of challenging patients, you're going to need to start discussing the transfer facilities early on. Hey, we're about to reach our capacity likely. What can we do as a community to kind of offset some of that volume? And also recognize limitations. What is your hospital going to struggle with if this is you working in the hospital setting? What can you do and what can you not do? Do you have a functioning trauma team? If you're going to have people showing up by ambulance, or like I said before, if people are going to be showing up by the front doors, which a lot of them will in mass casualty situations, what capacity do you lack? This is something that I'll be honest. You need to recognize the limitations before they happen. If you recognize them after the call has gone out, chances are it's already kind of too late. But if that's any opportunity, then know what your hospital can do and know what you can't do. Very good. You can go ahead and advance. Um, I want to spend a little bit of time talking about community resources. What else outside of the hospital we have access to? This is something that I've had the pleasure of of spending a little bit of time in here in Tucson, Arizona. I took this picture. This comes from a training, an outdoor EMS training in the Philippines. And I find looking all over the world at the way people handle disasters and disaster trainings, I find it fascinating and also kind of edifying. Like these guys have apparently a quite functional team set up right out there in the field. It's good to see that there are these resources that do exist, and we should use them as well. You can go ahead and advance. I think I'm talking first about EMS. So if you have, there's a handful of different styles of emergency management services, depending on where you are in the country, what type of of EMS capabilities you have, and what style you use. There are hospital-based EMS, there are fire department, publicly based ones, there are private ones. Everybody's EMS facilities are going to be a little bit different, but have an idea of what yours is because they are quite unique. I will say the EMS folks that I've had the opportunity to work with here in Tucson are have been very interesting in how much I can learn from them. But what service do they play? I will say early on, our EMS folks are going to be major players in terms of communication. That first call that we got from the radio room, that didn't come from me. That definitely came from them. They have the opportunity to, with boots on the ground, tell us what's happening and what to expect. Initial triage, as in like, wow, this kid needs to get to the ED right now, is also going to be done by them. Um, And hopefully, when that's functioning well, you will be receiving the sickest ones up front, the ones that need initial attention. And I have always been impressed by my my paramedic and EMT colleagues and their ability to recognize these sorts of things. The research team is something that I think we can sometimes maybe not ignore, but maybe we're just not exposed to. In addition to triage, initial management, and transport, our paramedic colleagues, especially those that work with the fire department, are trained in an amount of information gathering on the scene. I've had the opportunity to train some of them in particular with hazmat situations. But there's a decent chance that they can read the chemical identification numbers, and they have access to databases for, especially for hazmat, for chemical identification, even a lot better than we do in the hospital. So don't be surprised if they come to you and say, hey, I'm concerned that this was an organophosphate. There's a decent chance they know what they're talking about. Early decontamination and treatment. This is also an opportunity that our EMS colleagues have. Um, a lot of decontamination is going to be happening at the hospital side. If you have a very functional, especially tox medic set up in the team, you may get some of that beforehand. But early treatment is also something that these guys are able to do, even if it's as simple as starting an IV, starting some fluids, and getting them on oxygen. I gotta say, in the realms of toxicology and trauma, man, supportive care is second to none. And if you can establish that early on with a solid EMS group, you're already winning the battle. And understand that there are strengths that your particular EMS organizations may have, and there are also going to be limitations that they may have. You can go ahead and advance. This is one that I think can get neglected. I'm going to talk a little bit about the role of the Poison Control Center in these types of disasters as well. Poison control is something that I joke around. It's that everybody's mom has called poison control on them at some point. That certainly happened to me in my youth. But what we're seeing here from those that work in poison control centers is a lot of our work is now being done by the internet, which means that now a lot of our work is going to start being done by AI. So we can all kind of wince about that. But there is still a role for the Poison Control Center, and it has shifted somewhat. I think this, especially hospital and disaster management, the Poison Center is a real resource that can be underutilized if you don't know about us. So go ahead and advance once more. We'll talk a little bit about the history of poison control centers. It's fascinating, and I don't want to go too far into this because, frankly, if you let me talk about medical history, you will be here for 45 minutes, and I won't have even gotten to like the 21st century. But the brief history of the Poison Control Center is basically this one guy, Louis Dahlman, in Chicago working for Rush University. This guy was or sorry, Rush Medical Center. This guy was a pharmacist. And he basically, in the wake of World War II, he started seeing a lot of kids getting into their parents' pills and getting really sick from it. And he started just keeping a Rolodex, writing down, hey, captopril, hypotension, resolved well with fluids. Okay. So when he got the call from somebody in his hospital, says, hey, this kid ate a bunch of captopril, opens up the Rolodex, pulls it up, gives you the answer. Eventually, this guy couldn't leave his Rolodex behind. He had to keep it in the trunk of his car because he got so many calls, and he was on call 24/7. So eventually, he had to turn himself into an entire organization, which is the Chicago Poison Control Center. From there, we kind of were inspired by that. It moved to Switzerland, it moved across the rest of the US, and we now have the modern Poison Control Center. Which is, if you're not aware, it is staffed by a couple of different folks. There's usually a pharmacy director as well as a medical director. They each play different roles in business management and in protocol. The folks that are actually answering the phones are called spies, specialists in poisoning information. These guys vary between physician, nurse, and pharmacist. We're spoiled here. All of ours are pharmacists. I have learned so much from them. But they're the ones that have received special training on poisoning and on information as well as initial management. And it's basically all done as telehealth. They're the original telehealth providers. So staffed with our spies as well as our medical directors. I think the role of the Poison Center here can be forgotten because it can provide information early on substance identification, on initial patient management, on direction. Hey, which folks are going to need immediate transport and which folks can potentially even go home from the scene. And then one thing that can often be forgotten is that the Poison Center, we in poison control, we can contact the patients directly. We're available for not just in the scene direction and information, we do follow up on our patients. We'll call them a couple hours later, we'll call them the next day and say, hey, how are you doing? That for when you have a very large number of people, the ability to have a free resource that can follow up on your patients that are potentially going to be going home with minor injuries, don't forget that. There's a big help that your poison center can give in these situations. Just don't be afraid to, give them a call, learn what their capacities are, because if you've seen one poison center, you've seen one. Everybody's is going to work a little bit different, but establishing a relationship before you need them can be truly beneficial in these situations. You can go ahead and advance. I'm climbing up on my time, so I don't want to keep you guys too terribly long. I have a tendency to overspeak. Oh, good. I already gave these things. Excellent. You can advance another slide. Um, So, case continued. Our multiple patients arrive, are triaged in the ambulance bay to a trauma bay for initial trauma eval with decon, or initial decon followed by secondary reevaluation for our less severely traumatically injured patients. We get a call from our EMS folks. The research team is able to identify that they suspect this is nitric acid that we are looking at, that big red cloud spilling out from the truck. And we have multiple patients that are now complaining of respiratory symptoms. A great thing to do here, if you've not had to manage nitric acid personally, is to if you haven't already, now's a good time to call the poison center. Hey, we have these guys complaining of respiratory symptoms, and we just pulled them out from a cloud of what we've been told is likely nitric acid. What do we do here? What else do we need to keep an eye on? You can go ahead and advance. And let's also keep in mind that I told you this was a school bus of kids. There are always going to be pediatric considerations. These are my two sons from our camping trip where it was raining the entire time, and Eli could not have possibly cared less about the rain. He was just having so much fun. But I mentioned this, I bring the pediatric considerations up because these are important. Don't tell any of the pediatricians, but in the realms of poisoning, kids are kind of like small adults. Did you know that? Um, what I mean is mass is important. Mass and exposure make a big deal. A small substance, a small amount of a substance to a small person can be a pretty big dose. Children generally have a little bit more skin permeability, and when we're doing aggressive decontamination, we may see that actually worsen. And when we're looking at pulmonary irritants, of which there are myriad, our respiratory reserve and our kids are very, very important. So if we're looking at especially a potential nitric acid exposure, these couple of things need to be paramount on our minds. You can go ahead and advance our slides again. Decontamination considerations, things that this is going to be a review for you guys, but I don't want you to forget it. Children are going to need to be undressed. Modesty should be considered, should be handled as best you can. But ultimately, that's still a role of decontamination, and it may be a challenge depending on where you're at. You can advance it. It's going to be cold. Kids are small bodies. Even though Eli didn't care about that rain, that's because he was all wrapped up. You may not have any kind of heaters in your decon showers. There's a really good chance that you don't. And hypothermia in the setting of trauma is always is always a danger. You can go ahead and advance again. What kind of special needs concerns are your patients going to have? What types of assistive devices are they going to be bringing with them? How are they gonna be separated from those devices? What types of behavioral concerns are there going to potentially be? Our special needs populations are ones that are fortunately I'm happy to say they're present, and I'm happy that we have the opportunity to interact with them, but we need to be prepared for those kinds of things, and their needs are going to be different depending on the situation. You can go ahead and advance. And fear. Fear is always a chief concern. I just gave you three reasons why your patients are going to be terrified. This was a school bus. They're not coming with their families. These kids are now alone, getting shuffled about by people they don't recognize. getting undressed, getting freezing water poured on them. This is a very, very scary experience for anybody. Adults as well, but imagine that from the perspective of potentially 20 sick kids. Good. You can go ahead and advance. I'm a big believer in our child life specialists. When we have those at hospitals, they're such a big help. And there's also a good chance that depending on where you work, you may not have access to these folks. So what resources can you give to make a scary hospitalization a little bit more comforting to a pediatric patient? I just want you to think about that in terms of what your particular facility is going to look like. I know that in some places you just find the sweetest nurse, and guess what? He or she has now become your child life specialist for the time being. I've definitely worked in those situations, and other times it might be you. If once the dust settles, you might have to just sit down, hold some hands, and pull up Bluey on your phone for a little bit while you're waiting on parents to show up. Very good. You can go ahead and advance. I think we're wrapping up now. Nitric acid was confirmed as our causal agents here. Our patients were fortunately appropriately triaged, decontaminated, and evaluated. You found a handful of traumatic injuries, nothing terribly life-threatening, a couple of minor inhalational and ocular injuries resulting from the nitric acid exposure. Fortunately, those were managed by with appropriate supportive care, diagnostics, including X-ray, pH paper on the eyes, and thorough decontamination. A couple patients were watched in the hospital for a day or two with the minor inhalational injuries requiring oxygen, and a lot of the others went home and got a call from the poison center the next day. I think that's what we've got, guys. As the dust settles, I like to bring this up because once your disaster has concluded, it hasn't really concluded. You are going to have patients show up tomorrow saying, I breathed in something weird at this car accident yesterday. What's wrong with me? Keep in mind that people are going to be showing up much later from this same accident via different routes of entry. Your folks coming in through the front are going to come later than your folks coming in through EMS. You're going to need to get in touch with folks' families. You're going to need to do especially with this many kids, going to have to smooth some things over and make sure that kids have folks that they're going back to. A lot of things that are not going to be able to be handled in a single hospital. Hopefully, your EMS system is able to route people appropriately, but that's not always the case, especially when people are coming in by private vehicles and the such. And then even after it's done, days later, every one of these disasters is an opportunity to review your processes. Sit down, find the routes of failure that occurred at your facility and see what you can do to address them. It's great to handle these in simulation and without an actual disaster, but if you're in this situation, use it as an opportunity to improve on anything that your facility needs work on. Good. Think that's that, guys. Um, the good news is this particular disaster did not include a school bus, and we fortunately had a single casualty, and that was the driver of this vehicle. This happened about 10 minutes down the road from where I went to elementary school. This specific truck. So it's something that I just remember very distinctly. Like, yeah, I drove down this road on a daily basis in my childhood. And so these kinds of things happen, and all we can do is be ready for them before they occur. Thank you guys so much. I'm available for questions. I hope I'm able to address any, and otherwise, I'm grateful for the opportunity to speak with you guys.
Hey, does anyone have any questions for Tyler? Okay, well, if you do think of any, there will be an opportunity in a minute to ask him any questions that pop up. But right now, we are going to turn to stories of impact. So you should have received an email from me earlier in the month, kind of asking you to prepare something to talk about today. Over the last 18 months, you've heard a lot from us. So now we're hoping that really we can learn from each other. And by doing that, closing the series out also in a meaningful way. And so we're just asking you to share something from your organization. So if you would consider telling us about your site. So first, let us know your name, your role or position, where you work, and the types of patients you serve. And then if you wouldn't mind telling us about a strength of your TICD program or your team, a challenge or barrier in either your program or in your planning efforts, a recent success, surprise, win, or an idea for next steps, because we would like to keep this moving forward. So the momentum of preparedness, especially in our focus area, kind of keep that moving forward. So I do have the teams listed above. So let's see, we'll go to them. So Dell Children's Medical Center. Is anyone on the line from there that they would like to tell us about a strength, challenge, surprise?
Yeah. Deneen, can the other teams, I know I can come off mute. Can the other teams come off mute?
Yes.
Yes.
Laura
Okay.
shaking her head, yes.
Okay. My name is Jonathan Eisenberg. I am a pediatric emergency medicine attending at Dell Children's and the pediatric disaster medical director for the hospital. We have two hospital system. We have one hospital system. We're under Ascension, and then we have a community site about 25 minutes from our main site. So we have a lot to kind of work with. We're definitely the only regional hub. So we get a lot of questions from all of our adult colleagues kind of surrounding us and from the downtown site as to, what to do in these circumstances. And I think one of our biggest strengths that came out of all this testing was just how robust our hurt team is. We really stress that training. We send a couple people per year. So now I think our hurt team has like 27 members or something very high like that. And Oscar, who is our hurt team leader, is not on this call right now, but he maintains, and I will argue about this, probably the most organized decon room in the country. So we have sizing for everything. He's really got it down to an absolute art. So those are some of the things that we've really found to be great. One of our challenges we found was just moving the supplies around. We don't have the sort of large capability to move these huge boxes around. So getting the service crew from the hospital to kind of pitch in when we have to erect something was a challenging surprise.
Nice, thanks for sharing. So what I heard from his presentation is now we all have a colleague that we can go to if we need help with our hurt team, right? So Johnny has a very strong hurt team, 27 members. So if that's something you're struggling with, let us know. We can connect you. Also, organization of your supply rooms, right? Your decon centers. So if you need help there, I feel like Johnny also volunteered that.
I can
But
send
very
some
nice.
pictures. It's really beautiful.
Very nice. Thank you. Okay, how about Yale, New Haven? We'd love to hear from you.
Daniel Ebbs needs help unmute.
Yes, Doneen, I sent you a note and asked if you could close the slides, only because it would help me find people quicker.
I apologize. Thanks.
No problem.
Sorry about that.
Not your fault.
I felt helpless for a second there. I was trying to unmute and then put my video on and it wouldn't let me. It's great to see everyone. I'm a peds intensivist at Yale New Haven, also the co-PI for the PPN here. I think we had a lot of great strengths that came out of this project. I think one thing that I found is that before we did our large tabletop, we started having weekly meetings with our emergency management team. Before that, they were like ad hoc or like randomly once a month, but we really kept
that close communication, and that continued, which I wasn't really expecting, but it really facilitated larger health system discussions, planning for drills, etc. And I think one surprise that came out of this project was, we do a lot of work with some of the other kind of more rural community hospitals, and being able to leverage some of what we learned in our after action report from this initiative, we are able to apply when we're looking at disaster policy and integration into the emergency management system at those sites. And so I was really kind of excited and surprised to see how we could translate this from one site, kind of our core center, to these other kind of, more maybe less developed from a pediatric infrastructure for triage and decontamination sites. So very appreciative, and those are just a couple of the learning points we our strengths and surprises we took away from this. Thank you.
Wow, I feel like that's really wonderful to hear. Glad that you're able to do all that and accomplish that. Okay, so we have Texas Children's. Anyone on the line?
Hi, good afternoon, everyone. Can you hear me?
Yes, we can.
Oh, okay, great. My name is Lysandra Brown. I'm from Texas Children's Hospital, and I wanted to just share about, let me try to turn on my video. Let's see if I can. Oh, that's not working. Trying to turn on my video.
Try again, please. And
There.
Carrie, yes,
Hi.
Carrie, I was just going to tell you I fixed you.
Thank you so much. Oh, you can see me too. Great. Dr. Nicole Davis was supposed to be here, but I think she got pulled away for some other work. But I can share, I'm not sure the video that Sandy had, but I just wanted to share a little bit of the work that we've done with our decon program. We were really running into some challenges with our personnel resources and the time that it takes to train staff, and just the resource consumption, not only with paying staff and bringing them in and off hours to get this training, but also just the equipment and the literal lift of all of these supplies. As you guys know, these pappers, hoods, suits, boots, it takes multiple carts and truckloads to move anything around to any of our campuses. So we worked with our educators to break it down and take it in small chunks. And that's been a major win across our organization. We didn't require a full scale exercise right out the gate. We broke it down into these bite-sized chunks. So one day we were testing our tent, and that didn't require all of our EC nurses and clinical staff to come out. All we needed for that was our facilities team. So we addressed that with them. We found identified any leaks in our hoses, any equipment that needed to be repaired or replaced. And we addressed that then and there. And then we did multiple small tests with our tents to make sure they were up to par and working as they should. And then we did that same approach with our EC nurses. We tied it in with a training that they were already attending. So they have this quarterly training that happens anyway. And we said, well, can we just steal an hour or so of this training that nurses are already coming in for and do our donning and doffing and our hazardous materials awareness training? So we did that too. And I think that was just a really great takeaway from some of the things we've learned is, we're not trying to eat the elephant all at once, but we're taking it one bite at a time. And that seems to also reinforce, because we're not just having one big training once a year, but we're reminding them in these small doses of, hey, remember, this is what you learned, and this ties back to that training we did just a few months ago. So doing it like that was a lot more manageable for our leadership and for our nurses as well. So I think that was a great win from what we've learned.
I love
Sandy,
it.
if you want to add anything, go ahead.
Nope, that's good. Thanks, Carrie.
Yeah.
Perfect.
Well, that was really well said. I really love the idea of resources, you know, ooh, now I'm off camera. Resources, really utilizing those that are needed because it is hard to pull a lot of people into training, especially on the same day when surges are happening and everyday care is happening. So I think that's a really great point. And I also loved how you engage with your educators because, they're going to impact so many people even after that one exercise or training session. I mean, as they train new people or new employees come on, they're able to have these conversations with them and kind of tell the history of the training program as well, because I'm sure they see so much more than anyone else. So really a great job. Okay, UAB, Alabama, anyone on?
Hi, Mark Baker. We are a state verified level 1 trauma center, and we see we're getting close to 80,000 visits a year with about 80 ED beds in our pediatric ED. We have a small decon unit fixed with like 2 showers. But the big success I think that we had is formulating our HURT team. We were able to recruit a multidisciplinary team. We have, I think, less than 25. I think it's currently about 21 or 22 members who've gone through the training. We have equipment that everybody feels comfortable using. The big challenge has been recruiting outside of the ED, particularly nursing staff. It's been easier to recruit physicians and mid-level providers than it has been to recruit nurses. So that's been a major challenge. I think that one of the successes that we had is essentially writing a whole protocol or pathway for our chemical decontamination and having that added to our hospital emergency operations plan. So that was approved and added as an annex. So our next step is really to expand the team, try to get nurses, especially floor nurses, infection control nurses, with the goal that we would also be able to expand and respond to high consequence infectious pathogens, things like Ebola and viral hemorrhagic fevers. So that is our next step that we are aiming towards.
Wow, I like it. I like your path. So HURT checked, just expansion of that. Now just recruitment and continue to move on. I like it.
Yeah, and continue to develop protocols, and we'd also like to engage in more functional exercise, especially with our community partners. So that's all on the plate for the next year or so.
Nice. Okay, well, definitely reach back out and let us know how we can help. St. Louis, you're up next. Anyone on the call that can speak to St. Louis Children's Hospital? Okay. I don't see anyone, but put something in the chat if you're just not able to unmute, please. And we'll move on to Nemours, Children's Hospital of Orlando.
Hi, can you guys hear me okay?
Yes, we can.
Yes.
I'm Dr. Dwayne Duke. I'm the trauma medical director. Also, from Nemours is Dr. Giordano, and she's on the call. She may have some comments too. Here's one challenge that I kind of recognized that we haven't been able to fix yet, and I wonder if other places have a similar problem. So we've got a beautiful decon facility. We've got a lot of gear for Donna and Dolphin and being ready. We drill and we have a decon team, but yet what I've kind of failed to accomplish is that the people who are going to participate in those decons are putting themselves above and beyond risk of your normal workday, especially when the agents are not known. And from my military experience, and this is from also because I'm a colonel in the Army and 3 combat deployments, when we are in those situations, we receive hazardous duty pay. And you receive pay if you have incoming artillery in that area. And so it's recognized that you're an enhanced level of danger. And also, our participants in our decon teams need to maintain a high level of fitness. You can't go into that gear and try to start deconning patients if you are not physically fit. So there's the fitness requirement and then the danger with unknown, really subsequent downstream effects. And I really think that the people that are willing and brave to do this and step up and volunteer to do it and be trained to do it need to be compensated a little bit more than just a pat on the back or, that's a good team spirit. Thanks for stepping up. And I wonder if other organizations have had this or had these concerns. Thank you.
That is a great question. I don't know, Tyler or Johnny, did you have any comments for his question?
I was just making the joke that they'll just give you some pizza, but that's sort of the hospital hazard pay. There you go. I know we're kind of running into the same issue from what Carrie said and what you're saying, and I'm sure everyone's feeling the same financial burden is we can't pay anyone more time. The physicians don't want to kind of go in because they're already stressed, sort of time-wise to their max. So, and we can't offer extra pay to them. The nurses get training pay, but it's not very much. So, and then if you have to actually respond to something, where's that divide? So, I don't have a very good answer. I'm sorry. I don't know if Tyler's unmuted.
I wish I did as well, and unfortunately I don't either. We're in similar kind of financial restraints from that aspect. Apologies.
Hey, Larry, I think I see your hand up.
Yeah, we've gone through this as well. I think what we've had a challenge with is that when staff are appropriately trained, the risk is really low, right? And the organization really should be fostering, a culture of safety and protection. And it does become dangerous when you stratify um, the importance of specific care and perhaps implying that even with the appropriate training that there's an unacceptable level of risk. And so we've struggled with that because we could also argue that the emotional and mental stress of just a very busy unit is just as difficult and devastating and risky from a burnout and mental health standpoint as some of this work as well. And so for that reason, our organization has really not explored sort of that hazard pay model. We've really stressed the importance of our mission and that we provide care to anybody, and that as long as we embrace appropriate preparedness in training, that everybody will be kept safe. Certainly, from an emergency department standpoint, where there isn't that level of control for what enters your doors, you have to have a more universal model for that. And you can't necessarily have a culture or system where you can essentially refuse to provide care to a patient that comes in the ED because of a perceived level of risk. And so we've not explored that. I know there's good arguments on both sides. We've had some success with individuals sort of volunteering to have a stronger role, and that has given us more than sufficient numbers for things like this. But we do understand the challenge, and that may be easier said than done at many institutions, depending on their history and culture. and resources.
Okay, well, thank you for that. I think now I am turning it over to Johnny, who is going to talk to us a little bit about children's and youth with special healthcare needs.
You can just flip to the next slide. Yeah, so I think Tyler brought it up in his talk. I ran into these challenges when we were reviewing our plan. So I think just kind of something that we want to slip in as a pertinent issue is always just thinking about children with special healthcare needs, medically complex children when developing these sort of full disaster and response plans. So looking at not only their medical needs, which I think we're all really good at, but really the social and emotional requirements when kind of moving in between these models of care. What extra resources and staffing might you need? The accessibility, whether it's through the decon or when you're actually in the facility, and then all of the accessory materials that they may have, motorized wheelchairs, even a pet that might be with them who also would require decontamination. So there are a host of things, and all of us have sort of at least a few kids who we can think of off the top of our head that would be very tricky to kind of work through this system. But I think using them as sort of a model and then building out from that and identifying the barriers and challenges that come to mind when you're looking at these types of medically complex children. And then, just trying to build relationships and communication with subject matter experts. I know at my facility, we have something called the complex care clinic, which is a host of subject matter experts who deal with these kids on a daily basis. And they are the best resource for, hey, what do we do if, input your very complicated question. So I think kind of having them weigh in on the part of your disaster and response plan that would correlate with these types of children. And we do just want to say Dawn Bailey has a medically complex child who recently passed away. And she is a huge part of the PPN. So we offer her our greatest support.
Thank you, everybody. And thank you, Johnny, for that. Next, we're going to hear from our panel of speakers who have been our subject matter experts and leaders in this TICD initiative. So Tyler had to step away for another meeting. So we're going to include Larry Kosiolek, Nicholas Glom, and Johnny again to talk about their insights, their key takeaways, what stood out the most to them during these sessions, and where they think we ought to go next. So we're going to go first to Larry.
Hi, so thanks. I'm gonna talk a little bit about key learning points from our sessions. I represented the infection control related work of this domain, and I appreciate everybody attending, and it's been really great conversations on this. So, I think I could talk for an hour about, I think, the important stuff in infection control, but I think if you're going to take one thing away from an infection control standpoint about the things we talked about, it's ensuring that you use a systematic approach to protecting your staff and other patients from infections that come into your facility by employing the triple I framework. And that's identify, isolate, and inform. And so if you approach your policies and practices with that in mind, you will ensure that your staff have the appropriate ability to promptly identify potential communicable diseases as quickly as possible when they walk into your facility. Once they identify those as potentially infectious, they'll be able to promptly initiate isolation precautions for that patient to protect themselves and other patients from that disease. and then inform the key stakeholders who can guide and support the care of that patient. And so within those, there's several strategies, and ultimately those strategies will vary from facility to facility depending on what resources you have. But in general, for identifying diseases, it's very important that you have a level of anticipation and preparedness. And that anticipation can be based just on seasonal epidemiology in terms of what you expect based on the season and the typical pattern of diseases in your community. It can be related to doing risk assessments. The emergency management teams should be working closely with their infection prevention and control teams to have a joint risk assessment for specific diseases or special pathogens. It can be subscribing to local public health alerts so you know promptly what's going on in your community. Providers should be educated about those so that they can appropriately identify and are equipped with the right knowledge to do it. It's very important that you leverage your technology when you can. The medical records, particularly Epic, for example, and especially for settings like the emergency department, you can have built-in assessments that are done at the time of initial assessment of the patient that can ask a series of questions, generally or specifically related to specific pathogens. If those become prominent in your community, those panels can be pre-built and activated when there's an epidemiologic signal in your community that can walk those frontline staff through those, and based on the responses can use logic that can provide guidance and raise alerts for those diseases and then guide on next steps. It's important that you understand that you want to isolate first and ask questions later. So the initial suspicion of an infectious diseases, those isolation precautions should be implemented. Your hospital should have protocols for just general infection control and then more specific measures for certain classes of diseases, particularly those that are of higher epidemiologic importance and higher risk to healthcare workers and other patients, particularly things like measles and viral hemorrhagic fevers. Your staff needs to be trained on PPE. They need to be fit tested for N95 masks. They need to have that PPE immediately available so that there's no sort of logistical challenges to implementing those. Again, that technology that you may leverage in the last step can also provide guidance on those isolation precautions. And finally, it's important for you to understand what work with your facilities folks, understand what facilities measures you have for your hospital such as airborne infection isolation rooms and in rooms with negative airflow, private rooms, et cetera, to be able to safely physically isolate patients. And last, for informing, it's good to know who your key stakeholders are. Every emergency management team and the clinical team should know how to promptly get a hold of their infection prevention and control teams. You should know how to get in touch with your local Department of Public Health. You should anticipate which clinical support you'll need, particularly infectious diseases and others that can support staff. So those are my key learnings, and I really look forward to answering any additional questions on those aspects.
Thank you, Dr. Kosilik. In the last 10 minutes, Dr. Glom, Dr. Eisenberg, if there's anything you want to add and any closing remarks, since we are getting close to time. This is our last TICD session for now. So if there's anything that you'd like to share, Dr. Glom first, then we'll close out with Dr. Eisenberg, and hopefully Laura will have a minute or so to just summarize and close us out. Thanks.
Great. Thanks, Irene. Yeah, from a CBRN decontamination perspective, we've really been able to do a fairly deep dive into how children are impacted by CBRN events and really how they require special considerations for field triage, treatment, and transportation. And then we've also been able to highlight how emergency departments must invest in disaster preparedness for CBRN events involving children, and really ensuring that staff have participated in the planning, training, and exercises in all aspects of CBRN response. We've been able to share some potential funding resources and strategies for developing decon response teams, All these obviously are not without their own challenges. I'm not saying we've been able to tackle and solve all the problems, but I think this is a continued process. We've been able to discuss how community partnerships are key to successful CBRN response and recovery, and I've been able to really highlight the importance of maintaining knowledge, skills, and expertise in different CBRN agents and their respective countermeasures, including knowing how to access and how to use chem packs available in your region, and really just to ensure positive patient outcomes. As highlighted by Carrie Cox from TCH Today, certainly utilizing the QI approach and taking small bites and kind of chipping away at these plans as a main strategy to help move disaster plans forward is really one that we have embraced with DRC and recommend that you utilize going forward. And then certainly, effective internal hospital coordination and communication for planning, like Dr. Ebbs mentioned, they're doing at Yale, and coordinating and communicating during a CBRN disaster is really essential to assuring positive outcomes. We've had discussions on existing challenges with supporting staff training and response and the challenges, as mentioned today by Dr. Duke. And then different ways in which we can engage our hospital C-suite, identify key stakeholders within the hospital to garner support. Certainly frequent testing of the coordination, communication, and appropriate CBRN response needs is just one way that we can make sure that all partners in the hospital are up to date and comfortable with what we need to do. And then, as Johnny pointed out just in the previous slide, that children and youth with special health care needs certainly require additional consideration. So, encouraging all of our teams to incorporate that into their plans to make sure that we are caring for all children and their families. Thanks, Irene.
Thank you. Dr. Eisenberg, any final words that you'd like to share?
Just a few. So I think Larry and Nick really summed up everything that we've done in this last 10 plus months, or no longer, year and a half. Sorry, I'm getting my collaborators confused. Thank you everyone for showing up. We're really looking forward to kind of using this as a model for what we're going to do next and sort of what we're calling casually the DRC 2.0. And there will be a lot more details to come. But I think we've learned so much from everyone who's been involved in this, and I hope that us learning has also been impactful to all the participants who have been able to take away whatever they need from all of these great speakers and subject matter experts that we've had come through the collaborative. So I have really enjoyed the two-way street. I hope it continues. And then we'll have a lot more information to come. And Lara will just kind of touch on how we're going to try and stay connected in the coming months in a non-collaborative, but kind of collaborative fashion.
Thank you, Dr. Eisenberg. Laura, please close us out.
Thank you. Doneen, you can keep going. There you go. Stop there for a second. So while you're taking a look at this slide about the community of practice that will bridge the end of the DRC to a new DRC 2.0 collaborative in 2027, I want to mention that the session evaluation link and the details on how to claim CE, along with some other updates, are in the chat. Most of this information will be included in the follow-up message that we always sent out about a week after the collaborative, but we are thrilled to be able to offer a community of practice. And the difference between a quality improvement collaborative and a community of practice, as I understand it, I haven't been involved in one yet, is that the community of practice is participant-led. So when we do sessions, when we promote communication, it's based on what the participants want to talk about and what they want to share about how they are able to continue the important work from DRC into the future. So we're proposing an every other month session option in August, October, and January and beyond if the new collaborative isn't ready. So we're very excited about that. And there's an option through PPN Learn to provide a forum so that people that wanted to talk about disaster response in general, along with each of the focus area topics, can, like a bulletin board, talk, share resources, ask questions, and make suggestions for us to move forward. Next slide. This is the information on how to claim credit or CE. Next slide. It's also in the chat. So yes, while we are wrapping up our work in May and June, please do come to the full collaborative sessions. There are 10 more teams that are going to share their experiences in those sessions, and we'll have details on what you can do to wrap up the collaborative and help us move forward by sharing your ideas. That is my grandson, Jackson, heading off to kindergarten, and I think that I love sharing that slide because he's confident, he's going somewhere, he's not sure where yet, but he knows that he's going to do good and learn things in this world. And I really thank you all for your leadership in the topic of pediatric disaster management. Most of us have been involved in this field for more than several decades, and it is encouraging to see change happening because of the DRC and the PPN. Nick, anything final to say?
Yeah, thanks, Laura. Just as we're rounding out coming up, we have 2 minutes left. Really just wanted to thank all the hospital teams that have joined the TICD sessions since the inception of this group within DRC. And we really appreciate your level of participation, your eagerness to learn and share, and your commitment to improving the care of children in disasters. I really encourage all of you to continue to embrace the QI process, that community learning, as we just talked about, as you improve your disaster preparedness plans. You just continue to collaborate with each other, your local your local healthcare coalitions, and our PPN DRC team, in really sharing evidence-based resources and best practices. Definitely want to thank our physician and emergency management leads and subject matter experts, including Doctors Danielle Zer and Larry, who's on the call today. And thank you to Irene and Donine for your time, leadership, and expertise. And personal thank you to Irene and Donine for helping me and brainstorm and developing our CBURN curriculum. We're grateful really for all the speakers and subject matter experts, including Dr. Holscher's presentation today, in all of our TICD series. And a huge thank you to Drs. Johnny Eisenberg and Kate Remick and the rest of the DRC team, really for your vision in creating the DRC experience. And an incredibly special thank you to Laura Aird for her guidance, positive attitude, persistence, encouragement, and thoughtfulness in organizing all of the sessions. So huge thanks to all, and really just proud to be a part of this.
Thank you all. We hope to see you in May and June. Bye-bye.
Thanks, everybody.